Before we jump into health literacy, let's start with what literacy means to us. How would you define literacy? Most people will answer the ability to read and write. And while reading and writing are two of the skills needed for literacy, it is not the whole. Literacy represents not only reading and writing, but also math calculation, listening, speaking, and cultural and conceptual knowledge. So if we think about that collection of skills, as we read this next definition, think about how those skills are needed to use printed and written information to function in society, achieve one's goals, and develop one's knowledge and potential. The one thing that I would add to this definition, or maybe eliminate, is I might just say using information to function. This was written in 93, before we had smartphones, before the internet was what it is. So I am going to say literacy is using information to function in society, achieve one's goals, and develop one's knowledge and potential. So if we understand that literacy is a collection of skills, then it makes sense that the definition of health literacy will be inclusive of multiple skills as well. The Healthy People 2030 has used the following definition for health literacy. It is the degree to which an individual has the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. We use these skills every day. For example, comparing over-the-counter medication for cold and flu symptoms, looking up side effects or dosage amounts, taking the medication as prescribed, understanding the written and oral information given to us by healthcare providers, and completing all of the forms in the medical offices, our insurance papers, and etc. For a long time, health literacy definitions focused solely on the individual skill. In the past decade, researchers and healthcare professionals have realized the importance of the organization's health literacy for improving patient outcomes. The new mindset moves away from focusing only on the patient or client's abilities. That's because the old mindset led to some individuals feeling shame, embarrassment, fear, and frustration that can result from not understanding information, making medication errors, missing appointments, not meeting deadlines, losing our benefits. It's important to note here, we also tend to label our patients as non-compliant, non-adherent to treatment plan, difficult, challenging. It gives us a pause to look at where are these behaviors coming from. Is the non-compliance due to not understanding, not being able to make good informed decisions based off of the information they have? So the new mindset wants us to take into consideration that health literacy is not stagnant. It is not the same level each day. So my health literacy is fluid. When I'm at my best, it's going to be a lot better than when I'm stressed, when I'm challenged, when I'm not feeling well, when I have to make really important decisions, if I'm not feeling, if I'm not aware of what's going on. So the new mindset takes into consideration an equation. What are the person's skills and abilities, and what are the demands and the complexities of which they need to navigate through? So again, a person's health literacy is influenced not only by their skill level, but by the complexity and the demands that are placed on them. What demands and complexities do your patients face? Complicated paperwork, multiple agencies and healthcare professionals involved, people coming into their homes, difficult insurance requirements, paperwork, all of that. And then on top of it, what other demands are being placed? Are there family dynamics, people's schedules, trying to arrange complicated coverage? All of this plays into a person's health literacy. But the good news is, together, we can improve a person's health literacy skills. And that's by organizations equitably enabling individuals to find, understand, and use the information and services to inform health-related decisions and actions for themselves. In the moment, we may not be able to improve a person's reading or writing ability, but we can find ways to communicate clearly, confirm understanding, be culturally competent, and ensure they understand the information that they need to have and know. So again, we can ensure that they can find the information, that they can understand it, that they can actually then use the information and services to make the informed health-related decisions. And we're going to cover tips and tools that you as a home health aide or caregiver can use to improve your client's health literacy, as well as address your own health literacy as a professional. Health literacy and health equity are a focal point of the Healthy People 2030 plan, which was created by the U.S. Department of Health and Human Services to address the health and well-being of Americans. The focal point of this plan is to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. The term equity can sometimes be confused with equality. Sometimes we use this interchangeably. However, they mean different things. This image helped me understand it clearer. Sometimes a picture really is worth 1,000 words. Take a moment and think about this picture. What comes to mind? You can pause your video now to complete the second reflection question about what comes to mind when you see this picture. Does it change how you understood the term equity? Health equity is achieved when every person has the opportunity to attain his or her fullest potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. This definition is provided to us by the Center for Disease Control. Social determinants of health are conditions in which the environment where we live, where we learn, work, play, where we worship, and where we age affects a wide range of our health, our functioning, and the quality of life and outcomes and risks. Healthcare access and quality are affected by economic stability, education, access, and quality, neighborhood and built environments, social and community context. As I read the definition of social determinants of health again, put your equity lens on and hear the words and think about how social determinants of health may impact somebody's health equity. So they are the conditions in the environment where people are born, live, work, and play, worship, and age, and they are economic stability, our education, our access to health, the neighborhoods in which we're living. How do those things impact our health equity? The national standards for culturally and linguistically appropriate services in health and healthcare, also known as the National Class Standards, aim to improve healthcare quality and advance health equity by establishing a framework for organizations to serve the nation's increasingly diverse communities. The principal standard is the foundation for much of this training. You will see as we talk about the 5 C's of health literacy, the standards reflected in them. The principal standard calls for us to provide effective, equitable, understandable, and respectful quality of care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. What Dr. Nina and I really like about using the class standards is that they provide a way to improve quality of services to all individuals, which ultimately can lead to reducing health disparities and achieving health equity. The national class standards are about respect and responsiveness. They are a framework to help us learn how to respect the whole individual while responding to the individual's health need and preferences. Many times when I talk to people about using universal precautions in health literacy, it's not only confusing in that we don't typically use the terminology universal precaution in this manner, but what we're going to talk about as we go through this training is really how do you apply these techniques to everyone so that through our respect we can treat the person as a whole but still see them as individuals. And that sometimes people would challenge when they hear me say you need to implement universal precautions when communicating to folks. The pushback sometimes can be, well, but we want to be able to be patient centered or really address each person as an individual. And I say, yes, that's exactly what we're both saying. We're both saying the same thing, is that to be culturally responsive, to be respectful, that allows us to give services that are respectful, understandable, effective, and equitable. Class helps us take into account a person's cultural health beliefs, what their preferred language is, what their health literacy level is, and how we can help address that, and also the communication needs. And class helps us realize that it's at every point of contact that we need to be respectful and responsive. When we seek to improve our staff in cultural competence, language services, and quality of our services, we thereby increase our client satisfaction, engagement, and experience. And this will likely lead to helping increase a person's health literacy levels and overall their health outcomes. We can help improve the health literacy skills of those we care for by following the 5 C's of health literacy. The first one is clear communication. As kids, you may have played a game called telephone. You may recall it starts with one person whispering something into the ear of the person next to them, and then each person does the same until they reach the last person at the end of the line. The last person then stands up and says out loud what they heard. This often can result in laughter, confused looks, people shaking their heads. This is because almost inevitably, the last person has a different version of what the first person said. This can be fun as kids, but as adults, when we are communicating health information, it can have serious consequences. Think about this quote by George Bernard Shaw. The single biggest problem in communication is the illusion that it has happened. Rarely, if ever, does someone intend to confuse those that they are caring for with how they communicate with them. Yet, it can often be the result. It's a lot like the kids playing the telephone game. The intention was to accurately relay the information, but it gets changed as it goes. What can we do to make a difference? As home health aides, there is a way that you can improve the health literacy of those you care for, as well as yourself. One of the easiest ways for us to empower those that we care for is by using plain language. By using plain language, we are intentionally communicating with the goal of increasing understanding. This is done by common words or no jargon, slowing down, and chunking information. Did you know that medical professionals learn over 11,000 terms? No wonder it can feel like they're speaking their own language sometimes. And while it's easy to think only medical personnel or people in medical fields have their own jargon, almost every field you go into has their own language, esoteric language, a secret kind of knowledge. I remember when I started working in the Gerontology Institute, I had to ask for a glossary of all the different acronyms that went along with the gerontology field. So it is not just specific to medical, it's all of our fields. So it's just important that we remember as health home aides and other caregivers that we may be talking in a language that others may not always understand all of the words. One of the ways that we can do this plain language is to think about it in living room language, as the Minnesota Health Literacy Partnership calls it. And that's just something that we try to get ourselves in a practice of using. Instead of saying look for adverse reactions, look for bad reactions. And down through anti-inflammatory helps with the swelling going down. All of these words on the left hand side may seem very plain language to you because you see it every day. However, not everybody is familiar with those terms. What jargon do home health aides and caregivers use? As a home health aide or someone who cares for someone in their home, what jargon does your agency or other service providers use that could be considered jargon? Did you know what ADLs were prior to becoming a caregiver? Take a few moments to write down words that could be considered jargon for those that you care for. And what word or phrase can you use to make it into plain language? At this point, you can choose to write your reflection question on a sheet of paper, and at the end of the video, go to the Google form, or you can fill out the form as you go. The link or the QR code is here. Confirming understanding is our second C in strategies to addressing health equity and improving health literacy. To start off this segment, we're going to have you watch a quick video that's about 2 minutes or less that you can get to by either Googling house inhaler, following the QR code, or the link that's on the screen. Go ahead and pause your video and we'll see you right back here. Again, we draw off of George Bernard Shaw for this conversation. The single biggest problem in communication is the illusion that it has happened. What did you think about that clip that you just saw? As funny as it is, it's upsetting because it happens on a regular basis. While the scene and the series is fictitious, it's things that you as home health aides, caregivers, doctors, nurses, people who provide services for others come across on a regular basis. We deal with folks who struggle with understanding how to follow their treatment plan. And sometimes that is their skills, and other times it is ours. And like we talked about the new definition in health literacy, we're really focusing on what can we do in the moment to make sure that the person understands. And that's where confirming understanding comes in. Let's think again and use the example of the woman with the inhalers. When she saw her first doctor, at that point, the doctor had the opportunity to use his or her health literacy skills, which are the capacity to communicate clearly, educate about health information, and empower them. So at that point, their doctor had the ability to, in the moment, check in with her to see what she was getting from the conversation. Not to quiz her, not to make her feel bad if she didn't get it, but this is where we start to have the new mindset. We're looking at it now as Let's see how we're doing. We're going to, in this segment, look at empowering our clients, our patients, those we care for, to be able to test us in a way, be able to reflect back whether or not we're communicating what we had intended. So instead of assuming that it happened, we're making sure that there's an understanding. Now, the one thing is that we have to be careful not to use the cues that we have learned over the years that we take as confirmation. We have used and do use nonverbal cues such as head shaking, smiling, our body language, how we're standing. Those are confirmations that we have relied on, that I'm going to challenge you that for your confirming understanding, we actually need to have verbal confirmation, or somehow an affirmative that is teaching back to you, giving you the information that you have already given them. And why do you think we can't always, especially in these circumstances, when it comes to making sure someone understands their treatment plan, what they need to do, their schedules, why can we not just rely on that? Some of the reasons are that people are uncomfortable with admitting that they don't understand exactly what you're telling them. They don't want to look stupid. They don't want to. Um, they don't want to be embarrassed. So they there may be some insecurities on their side of why they're masking it. Also, we have people who have for many years learned how to mask their literacy skills, because along with having low literacy comes a stigma of being uneducated. And so people have learned how to hide that. So they will mask and use the nonverbal, and even sometimes yet answer yes and no to questions to just skirt the issue of them not letting you know that they're not fully getting what you're telling them. And sometimes they don't know that they're not understanding it. They may be shaking their head yes because they think they know what you're asking them, when in reality they haven't quite got what you were attempting to let them know. We have to assume they don't understand, and here are some different types that you may come across. I call the one the head bobber. My mother is the perfect example of the head bobber. This is somebody who wants to engage in the conversation, has great eye contact, and as she goes along is answering yes and affirmative to things, especially when it comes to her diabetic treatment plans. So a doctor can be asking her, how is everything going? Are you doing okay with your diet? Oh, yes. And, I was walking, and, even though walking isn't her diet, but so she wants to put out all the happy stuff. But if the doctor were to get into some more probing questions, they would have found that it isn't necessarily the story that she's telling them. So she head bobs a lot, and that happens a lot too when you ask people questions that are closed ended, and we'll talk about that in a couple slides. But the head bobber can be tricky because you think they're following right along with you. The other ones that we need to be concerned about is when they say, nope, I don't have a single question. Sometimes that's a signal that they may definitely have lots of questions. They just don't know where to start. Don't assume they understand. And this is sometimes we err on the side of making assumptions that because of somebody's educational professional background, they are automatically going to understand. So it's just as bad as making an assumption based on someone's lack of education, thinking that they're not going to understand the information. We also need to make sure that we don't assume that a higher education level equals higher health literacy skills. Remember that we can be stressed, not feeling well, have a lot of life changing events happening when we're in the midst of trying to make informed decisions about our health. And so we always need to make sure that we're checking in and confirming understanding. Somebody who's super chatty, who seems to just change the subject when you get on to asking them whether or not they're following along with where you're going. That can be a distraction technique. So that's one to be aware of. Also, if you have someone who parrots back and can say everything back to you exactly the way you told them, that doesn't necessarily mean that they can then act on the information. For example, they may be able to report back that they need to buy coated aspirins at the pharmacy, but when they got there, they weren't even sure what that meant, what to look for on the packaging. So you need to not take for granted just because somebody can tell you back exactly what you said that they can then apply it to their own. That's why a lot of times we will ask them to tell us in their own words how they understand what you have told them. As a home health aide or caregiver, you probably are aware of the numerous health professionals and other community organization staff that may be involved in your client's life. Think about from just one agency, there can be multiple people who visit the home, call, send letters, emails, texts. There's a lot of information being communicated back and forth. And it's not only from our clients that we need to confirm understanding, but for ourselves and with other providers that we're speaking with, we need to confirm understanding and make sure that we're all on the same page. I'm going to have you watch a video. Instructions for viewing are provided on the next slide. Before we watch the video, though, I'd like you to think about all of the different people who are involved in the caregiving of your clients or your loved ones. Think about who they interact with about their needs and their care plan. How many different people communicate and coordinate services through you as a member of their care team? You're going to either type in the address provided in a web browser, or you can use a QR code to get there directly. It's about a 4-minute video. You'll want to pause your video now. Takeaways from that video is that miscommunication can be fun when we're playing a game, and that the number of people relaying the information increases the chance for miscommunication and mistakes greatly. And I think we all know and realize that while miscommunication in a game can be fun, miscommunication around somebody's health can have some serious consequences. Another reason that we need to be concerned with confirming understanding is out of the Universal Precautions Toolkit from AHRQ. They have provided data that shows that 40 to 80% of medical information that patients are told during their office visit is forgotten immediately. And nearly a half of the medical information that they did remember was incorrect. So there's another reason why we can see that we need to take action and be proactive in making sure that people are able to get the information that they need and be sure that we're giving them an opportunity to teach back to us so that we can see where they are and where we need to troubleshoot and where we need to spend more information, time to give them more information. The teach back method is an excellent tool for the confirming understanding. The teach back method has three components: asking the patient to demonstrate their understanding, chunk and checking, and questions. Think about the woman from House who used her inhaler. If the first doctor had used the teach back method, she most likely would have used her inhaler correctly, and she more than likely would not have ended up back in the hospital to see somebody with continuing medical issues. So to start with the first part of it, where we ask our folks to tell us in their own words what they understand from what we explain to them. So we want to be sure that we're setting the stage, so to speak. We want to be present. We want to look at them. We want them to feel like we have time, that they're not bothering us. Sometimes they feel that we're so rushed, that our time is so short, that they shouldn't bother us with asking questions. So the little things we can do by just smiling, looking at the folks, and then making sure that we're always putting the emphasis that this is on us, that we want to make sure that we have explained it well. Not that we're trying to quiz them, test them, or catch them and make them feel bad for not understanding what we told them. And making sure that we check in as we're chunking the information down. So it's great that we, put the information into three manageable points, but what makes it even better is to stop and check in and have them explain what they understand so far. Because if the person missed the first concept and you keep going, the second and the third concept are likely not to have any context. And questions. The way we ask questions are so important. Open-ended questions really allow us to hear what's going on versus asking what they think we want to hear is going on. We should avoid questions like that can be answered with yes or no answers. We want to avoid ever asking, what do you have any questions? Because that easily is a closed-ended question that could be answered with no. We want to ask them and set the stage of what questions do you have for me? Making them realize that we're expecting them to ask us questions. So we want to encourage them, empower them to ask the questions. And we should be also working with them to make sure that they leave knowing the answers to the following questions. What is the problem? Why is it important to me? And what do I need to do about it? And we need to remember that The teach back is not just for doctors, not just for the people who are meeting behind closed doors with the client, not just the people who are the provider. This is for all of us. We need to confirm understanding too. And I'm going to have you watch another video. This is of a frontline staff receptionist demonstrating the teach back method while setting up an appointment. And you can go out to the video by following the QR code or using this YouTube link. Cultural competence is the third C of our strategies to addressing health equity and improving health literacy. First, let's define culture. Culture includes geographic location, sexual orientation, ethnicity, class, age, gender, race, religion, spirituality, and so on. Cultural competence means you are respectful and responsive to the belief, practices, and linguistic needs of diverse populations. We need to look at cultural competence as a long-term developmental process, which is best understood as a progression rather than an endpoint. A lot of times we want to just quick take a training, put some initiatives in, and boom, we're done, and that's all we need to do. But cultural competence really calls for continual self-assessment, attention to the dynamics of differences, and a commitment to the inclusion. Remember, we keep going back to respectfulness and responsiveness. So as overwhelming or daunting as differences, inclusion, and cultural competence can sometimes be, we have a tool that we'd like to share with you that's called the respect model. And we think this will be a really good tool to help you with managing cultural competence.
We're going to talk about the respect model today, and we're really excited to share this with you. It's a model that we came across when we were working on health literacy, and I had invited you down to help me with cultural competency and how to make sure that our training incorporated cultural competency. And actually we wanted to do just a module on cultural competency. Right. And together we found this respect model that we realized really needed to be in every module when we talk about health literacy, that it fits everywhere. And we are really excited to share this model with you because we think it's easy and it's really meaningful. So this model comes from the Office of Minority Health in their Think Cultural Health campaign. And they have an excellent communication guide that this is actually one of their tools that they provide. We both felt that the respect model was an excellent way to support health literacy strategies in clear communication, confirming understanding, while ensuring that cultural competency was always at the forefront.
The acronym for RESPECT stands for R, rapport, E, empathy, S, support, P, partnership, E, explanations, C, cultural competence, and T, trust.
So the respect model is an excellent tool or strategy to use in health literacy.
Yes, it is. And in fact, I've done a lot of cultural competency work, as you know. And one of the things you're always looking for is some sort of trick or some kind of thing that unifies everything. And the respect model gives most of the strategies that one would need to use in order to be culturally competent in any situation. Culture not just meaning racial or geographic, but also gender and age and all of those kinds of things so that you get the wide variety or the wide berth of what we do together in terms of health. All people that are coming for health are at a vulnerable position. And the one thing that makes people leave a situation that's health regarded is they leave it because they feel disrespected. In some way, someone has not attended to them in a way that they feel like they see the person. So this model, out of all the models I've ever seen, really goes through each piece that then helps you become more competent in dealing with people that you may not know or that you have never lived around or never been in conversation with.
This also seemed like a really hands-on, usable model. Like a lot of times we hear or see these models that you feel like, oh no, I'm going to have to know everything
Every single thing.
about every culture, and you get scared of like, am I
Right.
going to be able to do this?
Right.
And this is it's almost common sense.
Almost. And in fact, you're absolutely right, Karen, because what happens is when I'm finished with the cultural competency piece, like I'm sure you are, what happens is people go, well, I'm not going to be able to remember everybody.
Right.
And the point is, you don't have to remember everybody. You have to remember some general strategies that help you get to that person as they are, not as some group of theirs is.
Caring communication is the fourth C in our strategies to addressing health equity and improving health literacy. Caring communication is a big part of the other C strategies. We could cover it in the other areas, but as home health aides and caregivers, you have a unique role in your clients' lives. You get to spend most of your time with them in their home. You are in their own private space. You have an opportunity to connect with them as other healthcare professionals may not have. Your interactions with them are often the highlight of their day. You connect with them out with the outside world. You connect them with the outside world. You work with them to see their strengths. You get to see them at their best and sometimes at their worst. Caring communication is the ability to connect with your clients to find ways to build their health literacy. You may help them find a way to take their medications as prescribed by creating a pill chart or brainstorming strategies. Things that other people who aren't in their home may never be able to do with them. Caring communication is taking the time to meet them where they're at. Caring communication is listening to what is being said, what isn't being said, and really getting to know what their concerns are. This way you find ways to empower them to make informed decisions. Above all, caring communication lets your clients or your person know that you are respectful of being in their space at their time of need. Consistency at every point of contact is our last C strategy that we will discuss today in regards to addressing health equity and improving health literacy. When you see latex gloves or hear the word universal precaution, they usually go hand in hand. And this is because we soon learned that you could not tell by looking at somebody what their health condition was. So to protect ourselves, we needed to use universal precautions when dealing with bodily fluids. The same is true now for health literacy. Since we know and understand that you can't tell by looking at a person what their literacy level is, and that it can change from day to day, we now know that we need to apply universal precautions in regards to health literacy. And that means that at every point of contact and with every person, anytime anyone communicates health information. These 4 strategies are also universal precautions. Clear communication means to use plain language every time we communicate with someone, whether it's in writing, our web pages, whether we speak to them directly, whether it's a video, or whether we're calling them on the phone or if it's in person. The other is confirming understanding. So making sure that each time we interact with somebody, that we never assume that there's an understanding, that we make sure that we have confirmed their understanding. And cultural competence, making sure that we're respecting the individual and responding to their needs and concerns, that we develop effective cross-cultural communication, that we implement the respect model that we've talked about. The respect model is an excellent way for us to establish a rapport and to be able to show caring communication. The bottom line is it really comes down to respect each and every time. If we can respect the person enough to check in with them, to clearly communicate to them, if we communicate with an intention for them to understand and for the intention to be to help them make their decisions for themselves and others, then we have implemented universal precautions. We've come to our last and final reflection question. We're really happy that you took the time to go through this training and learn more about health equity and health literacy. The last question we'd like you to think about is explain how you, as a home health aide, can help your clients to improve their health literacy. So taking off of what we've talked about today, what is it that you can do that will empower the people you work with? We hope you've enjoyed the training. Please give us feedback on what we can do to improve, what other topics you'd like to see training on. And once you submit your reflection questions and evaluation, we will be sure to get out your certificate of completion. Thank you.